Bismillahirrahmanirrahim. This station is about a scenario of ovarian cancer, and this task usually comes as a long case, but it can be asked in simulated patient task. And you must know how to manage an ovarian mass in premenopausal women, how we can manage in postmenopausal women, what are the cutoff limits, where we can keep the patient conservative, where we have to go for surgery. And before discussing the scenario, I will briefly tell you the management of the ovarian mass in premenopausal and the postmenopausal women. So, Green Top Guideline number 62 is about the management of suspected ovarian mass in premenopausal women. And in premenopausal women, we do the management according to the B rules and the M rules on transvaginal ultrasound. B rules mean that these are the benign features, and M rules mean these are the malignant features. And this is IOTA group ultrasound rules that classify the masses as benign or malignant. IOTA means International Ovarian Tumor Association. Okay. So B rules are if the cyst is unilocular, and it will be benign. If it is having irregular solid tumor, it is more in favor of the malignant. And the other B rules are presence of solid components where the largest solid component is less than 7 millimeter. Okay, solid components are present, but the largest solid component is less than 7 millimeter, and there is presence of acoustic shadowing. The tumor is smooth multilocular with the largest diameter less than 100 millimeter or 10 centimeter. Okay, and there is no blood flow on Doppler. So these are the B rules, that tumor is unilocular, the presence of solid component, but the largest solid component is less than 7 millimeter, presence of acoustic shadowing, and tumor is smooth multilocular, largest diameter is less than 10 centimeter, and there is no blood flow. And if we talk about the M rules, tumor will be irregular and solid. There will be presence of ascites, at least 4 papillary structure. Okay, if there are 3 papillary structure, it is in favor of benign. But if there are 4 papillary structures, it is in favor of M rule. And irregular multilocular solid tumor with largest diameter more than 10 centimeter. Okay, more than or equal to 10 centimeter. If it is 10 or more, then it is in favor of malignant, and there is very strong blood flow. So according to these rules, you will classify the ovarian mass as benign or malignant. Then the other thing is that how we calculate the risk of malignancy index. Risk of malignancy index, it combines 3 features, that is serum CA-125, menopausal status, and the ultrasound score. And we calculate the risk of malignancy index by multiplying ultrasound score with the menopausal status with the serum CA-125. And the ultrasound score is 1 to 5. Okay, and how we score? uh, There are 5 features that we take on ultrasound, that is multilocular cyst, solid areas, presence of metastasis and ascites, and lesions are bilateral or not. And if there is no score on ultrasound, means the all of these features, they are not present on ultrasound, then the score will be 0. And if there is only one feature on ultrasound among all these 5 features, then the ultrasound score will be 1. And if there are 2 to 5 features, then the ultrasound score will be 3. Okay. And the menopausal status score is 1 if the patient is premenopausal, and the score is 3 if the patient is postmenopausal. And the postmenopausal can be defined as women who have had no period for more than 1 year, or women over the age of 50 who have had a hysterectomy. Okay. This is the definition of the premenopausal and the postmenopausal. Then regarding the serum CA-125, serum CA-125 is measured in international units per ml, and it can vary between 0 to hundreds, even thousands of units. So in this way, we will multiply all the three parameters and we will calculate the risk of malignancy index. And a recent systematic review shows that sensitivity and specificity of RMI score of 200 in the detection of ovarian malignancy, it will be 78% sensitivity and specificity is 87%. So these questions you may be asked in the MCQs, in the EMQs. So you must be clear about these scoring system, that how you can calculate the RMI and how you will give the scoring according to the ultrasound features, and the how you will calculate the menopausal scoring and the CA-125. Okay, so this is about the uh, risk of malignancy index and the B rules and the M rules. Okay, then in the menopausal, in the premenopausal ladies, there are the different cutoffs. Okay, for example, if the patient is having asymptomatic simple cyst, then how we will manage in the premenopausal woman? In the premenopausal woman, management is according to the size and the, as we have discussed, that according to the B rules and the M rules. Now we have done the ultrasound and patient is having simple cyst, and along with this patient is asymptomatic. Okay, there are no M rules, all the B rules are present. So the management will be according to the size of the cyst. If the size is less than 5 centimeter, that is till 4.9. If it is 5, then it will move to the next category. If the size of the cyst is less than 5 centimeter, that is still 4.9, then no follow-up is needed. It will resolve in 3 cycles. If the size is 5 to 7 centimeter, then we will do follow-up at 1 year. 45% of the cysts, they will resolve spontaneously. Okay. And if the size of the cyst is more than 7 centimeter, 7 centimeter, if the size is 7 centimeter, we will do follow-up at 1 year. But if the size is more than 7 centimeter, that is 7.1 or more, or it is persistent asymptomatic cyst, then we will do further imaging. That is, we will do MRI and we can plan the surgical treatment in the form of laparoscopy or laparotomy according to the size of the cyst. So these cutoffs you must remember while attempting the MCQs, while attempting the EMQs. Very close options they are given in EMQs and MCQs. Like you may face a scenario that like the size of the cyst is 7 centimeter and the options will be you will do follow-up at 1 year, you will do the conservative management, very close options. So these cutoff limits you must remember, that if the size is less than 5, then no follow-up. If the size is 5 to 7, then follow up at 1 year. If more than 7, that is 7.1 or more, then you will do the further imaging and you can plan the surgical intervention. This is about the asymptomatic simple cyst in premenopausal women. Okay. Then if the cyst is complex, it is having any M rule and the patient is premenopausal, then what you will do? Straight away, you will go for tumor markers, and if they are raised, we will refer the patient to the gynae oncologist where MRI will be done and further management will be planned. So, if the cyst is simple, then management will be according to the size of the cyst. But if the cyst is complex, no matter whatever is the size, you will go for tumor markers, and if the tumor markers are raised, you will refer to the appropriate specialist and where the further imaging will be done and further management plan will be discussed with the patient. Okay. Next is about the management of the ovarian cyst in the postmenopausal woman, and this is a green top guideline number 34. And this is the flow sheet. All of you must remember this flow sheet. In postmenopausal women, any cystic lesion is important if the size is 1 centimeter or more. Okay, so even if the size is 1 centimeter, which is normal in premenopausal women, but it is not normal in postmenopausal women, then we will follow this flow sheet. If the size of the cystic lesion is 1 centimeter or more, we will measure CA-125. Along with this, we will do transvaginal ultrasound with or without transabdominal ultrasound, and we will calculate the RMI score as we have discussed above. RMI score is calculated by multiplying the ultrasound score along with menopausal status, that is 3 in postmenopausal women, along with CA-125. Now the further management, it will depend on the RMI score. If the RMI score is less than 200, the patient is having low risk of malignancy. But if the RMI score is more than or equal to 200, okay, this is 199. RMI is less than 200. But if it is exactly 200 or more than 200, then the patient is having increased risk of malignancy. Then how you will manage if the RMI score is less than 200? If the cyst is fulfilling all of the following criteria, that is, it is asymptomatic, cyst is simple, it is less than 5 centimeter, and it is unilocular and unilateral. Okay. Then how you will manage? You will consider the conservative management. Okay. And what you will do in conservative management, you will repeat the assessment in 4 to 6 months, in which we will do CA-125 along with transvaginal ultrasound after 4 months, and we will see if the cyst has resolved or not. If the cyst has resolved, then we will discharge the patient. But if there is any change in the features of the cyst, then we will consider intervention, that we will do MRI and will plan the further management. And if the cyst is persistent and it is unchanged, okay, then we can repeat the assessment in another 4 to 6 months, and we can individualize the treatment after discussion with the woman. So there are 3 fates. If the RMI is less than 200 and the cyst is asymptomatic, simple, less than 5 centimeter, unilocular and unilateral, then we will repeat the assessment in 4 to 6 months, in which we will do CA-125 along with ultrasound, and we will see that it has resolved. Then we will discharge the patient. If there is any change in the features, we can consider intervention. If it is persistent or unchanged, we will repeat the assessment again in another 4 to 6 months and individualize the treatment according to the patient after discussion with the patient. And the second block of this flow sheet is that if the cyst is having any of the following features, that if the patient is symptomatic, it is non-simple, size is more than 5 centimeter, and it is multilocular and bilateral, then what we will do? We will consider surgery, that is salpingo-oophorectomy, usually bilateral. Okay, we will not do a hysterectomy, only salpingo-oophorectomy, that is bilateral. Okay, then come to the other side. If the RMI is more than or equal to 200, then the patient is at increased risk of malignancy. Immediately, we will refer the patient for CT scan of the abdomen and the pelvis, not only the pelvis. Okay, we will do the CT scan of the abdomen and the pelvis, and we will refer the patient for gynecological oncologist and MDT review. After this, we will see that according to the MDT review, patient is having a high likelihood of ovarian malignancy or low likelihood of ovarian malignancy. If she is at high likelihood of ovarian malignancy, then laparotomy will be done, full staging procedure by a trained gynecological oncologist. Okay. But if there is a low likelihood of ovarian malignancy, Then laparotomy will be done, in which pelvic clearance will be done. With that will include total abdominal hysterectomy along with bilateral salpingo-oophorectomy, omentectomy, along with peritoneal cytology by a suitably trained gynecologist. Okay. Here the gynecologist can do the surgery. But if there is a high likelihood of ovarian malignancy, the surgery will be done in a specialized center by a gynecological oncologist. Okay. So in this way, we will manage the cyst in the postmenopausal woman. So here you can see that the cutoff size is 5 centimeter for the conservative management and for the surgical intervention. But in premenopausal women, the cutoff sizes, they are less than 5 centimeter, 5 to 7 centimeter, and more than 7 centimeter. Now we will come to the scenario that there is a patient who is 42 years old. She is para 2. She complains of increased left-sided abdominal pain for the past 6 months. It becomes worse to the degree that she needs daily painkillers and it is interfering with her job as receptionist. Her bladder and bowel habits are normal. She has regular menses of 7 by 28 days and she was taking combined pills, but she has stopped taking it several years ago. She is otherwise fit and well. She denies any medical problems and she is not taking any medicines besides analgesics. On examination, her BMI is 23. There is fullness in the left head nexa, but there is no obvious mass or ascites. The vulva, vagina, and cervix all are normal, and she had normal anteverted uterus. On investigations, pelvic ultrasound and CA125 were requested. Pelvic ultrasound report shows that she is having normal anteverted uterus. Endometrial thickness is 7 millimeter, and there is a left complex ovarian mass of 12 into 8 into 10 centimeter, having solid and cystic component, and there is a fluid in the pouch of the Douglas, and right ovary is normal. CA125 is 950. Okay. So how will you manage this patient? You will start the station like any other station. You will introduce yourself. You will make a rapport with the patient. You will tell the aim of the consultation, explore her concerns and expectations, set your agenda, and then you will take the history. This history you can take in a simulated patient task. These questions you must know that whenever you face a case of an Excel mass in the long case, these questions you will ask from the patient. Then you can tell in a structured discussion task that you will ask these questions in case of an Excel mass. Always start your history with an open-ended questions that can you tell me more about your pain? Is there anything that makes it better or worse? Have you tried anything for the pain? Is it affecting your quality of life? Do you have any problems with your bowels or water work or urine? Do you have any complaint of bleeding or abnormal discharge? Do you feel that your tummy is growing in the past few months? Do you have any symptoms of bloating? Is there any loss of appetite, loss of pain? Do you have any chest pain? Okay, so all these questions, first of all, you will ask about the detailed history of the pain. Then you will ask about any metastatic symptoms, problem with the bowel or the bladder, bleeding or abnormal discharge, pressure symptoms along with this. Then your tummy is growing or not, bloating, and then cancer symptoms like loss of appetite, loss of pain, okay, chest pain. Then you will take the gynecological history. Can you tell me more about your period? When was your last menstrual period? Is she up to date with her smears? Is she using any contraception? Okay, has she ever been pregnant before? What are her future fertility plans? Then you will take the past medical history, surgical history, drug history, social history. Family history is very, very important. Okay. If you don't ask about the history of the ovarian cancer in the family, this will be the failing point in this station. That is there anything that runs in the family history of breast cancer or ovarian cancer? In this station, patient is telling that her mother had cancer breast 3 years ago at the age of 65 and she was treated and doing well now. And there is no genetic abnormality. If the patient is so much educated and she knows this much, she can tell you. Okay, after the history, you will do the examination, you will calculate the BMI, you will do the general physical and the abdominal and the vaginal examination. And if it is already mentioned in the scenario, then there is no need to go for this examination, and then you will not waste your time. After this, you will explain the results to the patient. You will do the all the steps of the breaking bad news. Okay, you will give the warning shot that are you alone, or do you want to call someone with you? Okay, you can tell that I have confirmed the name and the hospital number on the reports, and this report belongs to you. But I am so sorry that I don't have a good news to discuss with you. And you can tell her that I have some concerns regarding your scans and blood tests. The scan is showing that you have an ovarian cyst, which is a fluid-filled bag in your left ovary, and it is quite big in size, and it has some concerning features that it contains some solid parts. And the blood test that has been done, it is a protein known as CA125, and it is much increased than normal. Okay, but along with this, you can tell that it is increased in many other conditions like infections and cancers or endometriosis. Uh, but we will do the other test to confirm that why it is raised. Okay, so in this way, you will explain to the patient that about the results of the ultrasound and about the result of the CA125. Then the patient will ask you that, do you mean that I have cancer ovary? You will tell her that from the results here, together with your age, your history, and your mother history also, we calculate the risk of having ovarian cancer. And I am so sorry to tell you that there is a high risk of having ovarian cancer in you, but we will do some more tests and ultrasounds or scans to confirm that there are any sinister cells or cancer cells in this cyst or not. Okay. So the final diagnosis is after histopathology. So we cannot say in this way, like we cannot say 100% that it is a cancer or not. We can tell her in a way that we have calculated the risk, and by taking account your age, your mother history, and the results of the ultrasound and the results of the blood test, the risk is high in your case, but we will do other more blood tests and the scans to confirm that there are any sinister cells in this ovarian cyst or not. And what we will do for confirmation, we need to do more advanced scans that is known as CT or MRI scans, and we will do surgical intervention to have more clear idea about the cyst. Okay. We will not say in the way that it is malignant straight away. We will say that we will do advanced scans and we will do surgical intervention, and then we will have a clear idea. And we may also need to do X-ray test and camera test to check for your stomach and bowel. And your care will be managed by a team of doctors, including consultant, gynecologist, and oncologist, specialist nurse, radiologist, pathologist, and they will examine for sinister cells in the tissue after surgery. Okay. Then the patient can ask, can I have a keyhole surgery or laparoscopic surgery? And can I go home in the same day? You can tell her that after the MDT meeting, you will need surgery after your consent, and it better it is to be done in a cancer center to remove your left ovary through a cut in your tummy or through a keyhole surgery, so you can be discharged early. But in most of the cases, the if you are suspecting a cancer, we have to go for a staging laparotomy, and we will do a open surgery, not the keyhole surgery. Like in this case, we can tell her that the cyst is big enough and it is 16 centimeters, so it will be difficult to remove by the keyhole surgery. and we may need to be removed it through a cut in your tummy that is known as staging laparotomy. And after removal of the ovary, it can affect your fertility, but still you can pregnant by the other ovary. And we can't confirm that it is benign or malignant except after sending the biopsy. Uh, okay. And after the ovary will be removed, it will be sent to the pathologist, then the tissue diagnosis will be made, then we can give you a clear idea that it is benign or malignant. Then we give whenever we tell a surgery to the patient, we will tell the possible risk of the procedure that can be injury to the internal organs, injury to the ureter, bladder, bowel, blood vessels, and there are risk of blood transfusion, blood clots in the lungs, risk of infection and anesthesia complication. Okay. And then we will also tell her after, then we will also tell her about follow-up after the operation, that after the operation you will need follow-up, and you may need for further surgery or chemotherapy. It will depend on the nature of the cyst after examination by a specialist doctor. Okay. Then here the patient is asking a question that can I postpone the surgery? I am busy with my job. Then we will tell her that it's better not to delay the surgery because there can be twist of the ovary, and in that case you will need an emergency operation, and emergency operation carries more risk and it can affect the ovarian function. In this case, patient is having a history of cancer in her mother, breast cancer. So we will refer her to the genetic counselor. We will, in any cancer case, we will connect the patient to the support groups. We will give patient information leaflet and we will fix her appointment with the consultant. Okay. So if you have any question, you can ask me. Thank you very much.